chair this talk, we have Dr. Ramachandran, Senior Consultant Radiologist, Anandaburi Hospitals and Research Institute. And I also invite the speaker, Dr. Ajay Alex.
Good evening to all. I thank the organizers, Dr. Pradeep Kadangur and Dr. Arun for giving me this opportunity. I am happy to introduce Dr. Ajay Alex. His parents are well known to me, and Dr. Alex Sitiera and Dr. Lali Alex, you all will be knowing. And Ajay Alex had a very good career in radiology, and we would now like to hear from him.
So, very good evening to all of you. I would like to thank the organizers for giving me this opportunity to be sharing the dais with such a vast list of eminent faculties, many of whom were actually my teachers in radiology as well as in medicine. So in the next 10 to 15 minutes or so, I'll take you through the journey that interventional radiology has actually translated into improving patient care. So in my talk today, I'll take you through the brief history before I touch upon the basic requirements, and the larger part of my talk will cover the basic or the more interesting of the interventional procedures that are on offer from our side before I conclude today's session. So the journey of interventional radiology actually started way back in 1896 when Hashek and Lindenthal directly punctured an artery of a cadaveric hand and then took an X-ray. This was after Röntgen discovered the X-ray. But then interventional procedures did not actually get a kickstart until an access issue was actually solved. So it was only in 1953 that with the description of the Seldinger technique that an access to an artery with a vascular sheath was possible. And later on, a decade later, Charles' daughter went on to do the first peripheral angioplasty. And this was the 80-year-old female who actually had a limb salvage post the first peripheral angioplasty procedure by Charles' daughter. So to do an interventional procedure, the basic workhorse is the DSA system, which is basically the digital subtraction angiography system, which basically is a fancy X-ray system. You also require interventional hardwares, which the basic one being the arterial or a vascular sheath. You have certain catheters based upon which vessel you need to cannulate, which you can take to the particular location with the use of certain wires. Now you also have balloons as well as stents in order to open up occluded or stenotic vessels, and various embolic agents are available in order to occlude vessels that are abnormal or probably not necessary. Now you necessarily do not need an IR to do all your procedures. Even a trained or an experienced radiologist can also do almost most of these procedures. You also require a good support system, which includes your nursing staff, your radiographers, and more importantly, the referral doctors, because all specialties have one or the other role wherein you can have your patients sent to an interventional radiologist for a treatment option. So now with the advent of lot of advanced hardwares, gone are the days when we were largely doing difficult biopsies and percutaneous drainage. Now I think there is probably not many or probably no specialty wherein there is a role, where there is no role for an interventional radiologist. Probably the only one that I can think of now is probably dermatology, where probably we may in future also have certain roles. So I'll take you through the various interventional procedures that we have on offer. So starting from the head, to diagnose basically the vascular abnormalities of the brain. So this is basically an angiography of the internal carotid artery, the intracerebral circulation, wherein the entire branches of the IC are clearly depicted. This is similarly of the vertebral artery in the intracranial region. Not only in diagnosing, but likewise you can diagnose vascular abnormalities wherein in this particular patient there is extravasation of contrast into the cavernous sinus. So this basically becomes a carotid cavernous fistula. Also you can diagnose and delineate well in detail the feeding artery as well as the draining veins in cerebral AVMs. Now, not only in diagnosing but also in treating abnormalities in the cerebral circulation. So this was a 64-year-old patient who presented with subarachnoid hemorrhage with intraventricular extension, whom on angiography was detected to have an ACOM aneurysm. So this aneurysm was managed endovascularly by the use of platinum coils, which are used to pack the aneurysmal sac so as to exclude the sac from the circulation. So depending upon the aneurysm morphology, we have certain other devices as well, which is called as a web, as well as in wide neck aneurysms, you have what is called as a flow diverter. Now, not only in delineating the vascular abnormality in an AVM, you can also manage them endovascularly, wherein we use liquid embolic agents to occlude the AVM nidus in the brain. Now, the advantage of doing these procedures endovascularly is that most of these patients will be back to their routine life in under 7 to 10 days, unlike an open surgery. This was another patient who post-trauma developed a carotid cavernous fistula. So this is the superior ophthalmic vein which is filling in the arterial phase. Now the same was confirmed in the angiography with efflux of contrast in the cavernous sinus and further into the SOV. This was also coiled off, the fistula was coiled off, and the patient developed good results and was back to his normal activity within about 1 week. Now, an acute emergency where interventional radiologists play an important role is again in regard to acute stroke. So this was a patient who had a right hemiplegia with CT angiography showing a cutoff of the left middle cerebral artery. The angiography also confirms the occlusion in the left MCA with non-perfusion in the MCA territory. Now we have devices, something which is called as a stent reaver or suction devices, which will basically suck out the thrombus in the occluded segment so as to establish the antegrade flow in the MCA. Now coming down to the neck, majority of our interventions in the neck region are basically for preventing significant bleeding at the time of operative procedures. So this was basically a carotid body tumor, and this being a juvenile nasopharyngeal angiofibroma, both of which were embolized preoperatively. This was the preoperative angiography and the post-embolization angiogram that shows the reduction in vascularity in the tumor in both the cases. Both the patients underwent surgery uneventfully and is back to their normal life. Coming to the chest, patients who have massive hemoptysis, in whom CT shows hypertrophied bronchial arteries, they can be selectively cannulated and embolized so as to reduce the hemoptysis. Also, patients who have pulmonary AVMs, as in this case, wherein CT also shows the AVM in the peripheral lower lobe in the left lung, can be managed endovascularly by occluding using an embolic device which is called as a Amblatzer plug. Now, this was particularly a case of an Osler-Weber-Rendu disease. Now, coming to the gastrointestinal system, one area where IR has revolutionized treatment and is probably now a standard of care is with regard to hepatocellular carcinoma. So this was one of our patients who had a large HCC in segment 8 of the liver. We did what is known as a transarterial chemoembolization, wherein angiographically we cannulate the feeder artery and then embolize it with a chemotherapeutic agent, which was epirubicin in this case, and the post-operative MR, which shows complete response. We also have options of radiofrequency ablation as well as RF ablation of lesions, as well as radioembolization, acetic acid ethanol injection for tumor management. Also, with regard to visceral artery aneurysms, this was a case with pancreatitis with a celiac artery aneurysm, which was also managed endovascularly with the help of coils and exclusion of the aneurysm. Also, Budd-Chiari syndrome, wherein treatment options were limited, basically involves occlusion of the hepatic vein in the IVC segments. So we can open up the hepatic vein with a venoplasty, or in patients who have all the 3 hepatic veins which are occluded, we can do a procedure which is called as TIPS or DIPS, wherein we theoretically create a shunt from the hepatic vein to the portal vein, ensuring antegrade flow through the shunt. Also, in mesenteric arterial occlusions, as in this case of celiac artery and SMA occlusions, we can open up the occluded segments and stent them and relieve the patient of the chronic abdominal angina symptoms. Also, in patients who have post-traumatic splenic lacerations with contrast extravasation, can be embolized endovascularly to stabilize the patients. Also patients who have biliary malignancies, whether it be cholangiocarcinoma or CA pancreas. Now biliary drainage procedures, either external or internal stenting, with the option of doing brush biopsy is also an option. With regard to urological interventions, one of the relatively recent intervention is with regard to prostate artery embolization for management of patients who are having BPH. Now, we have also been to the rescue of limbs that are on the verge of being amputated, with this being a patient who had an SFA occlusion, which was angioplasty using balloon to ensure that there is antegrade flow. Now, with the advancement of hardwares, we are now also able to angioplasty even infrapopliteal vessel, and for that matter, even pedal arch, especially in patients who benefit are the diabetic patients. Now, this was another patient who was a auto driver from Tamil Nadu who had acute limb ischemia. This was a normal vessel on the right limb. There was no flow in the left limb with bluish discoloration in the distal limb. We did a catheter-directed thrombolysis in order to re-establish flow in his left upper limb, and the patient is back to driving his auto rickshaw back in Tamil Nadu. Now, coming to aorta, you have the option of keeping stent grafts if it is for the thoracic aorta, which is termed as TVAR, and for abdominal aorta, it is termed as EVAR. So basically, you are keeping a stent across the aneurysmal segment and excluding the aneurysmal sac, thereby ensuring that the patient gets back to his normal routine in about 2 weeks' time. Also, CKD patients who are on dialysis, the fistulas can be opened up peripherally, as well as the central veins that develop stenosis can be opened and stented as and when required by the interventional radiologist. We have also come to the rescue of gynecologists, wherein PPH with the advent of uterine artery embolization being one of the options. Also in adherent placentas, as in this particular case, we have embolized the patient's uterine artery in order to ensure that there is no bleeding intraoperatively. Now, you can also do this for management of uterine fibroids, AVMs, as well as pseudoaneurysms. And given a chance, I can actually go on speaking about the various pathologies wherein we have a role, probably till the next MEDICINA in 2024. But to give you an outline, we now have options of managing varicoceles with gonadal vein embolization. We have varicose vein management options, DVT in all transplants, whether it be renal or liver. We can manage gastric varicose bleeding, especially fundal, with what is known as a BRTO procedure. We not only can ensure patency of already surgically created fistulas, but we are now on the verge of being able to create fistulas as well. And also in order for weight reduction with left gastric artery embolization being also on the advent. So to conclude, these are generally minimally invasive procedures which ensure that the patient can return back to normal activity with a shorter ICU and probably a very short hospital stay with very little major life-threatening complications. The flip side of this is basically the cost of procedure because of the hardwares involved and naturally the availability of hardwares, which will be solved in the coming few years. Thank you.
Thank you, Dr. Ajay, for sticking on to the time exactly. And this is a vast topic. We are having an overview of the same. And the main problem is selection of cases, interdepartmental dialogues and all. How do you feel?
Actually, personally, when I started my IR career, I was actually skeptical whether patient referral would happen, or not. But I think clinicians are much more understanding and they are relatively much more aware. And interestingly, they are much more aware than actual radiologists per se. So initially, before my training period, I myself did not know a lot of these procedures which could be offered to a lot of patients. But on the flip side, clinicians are more aware presently also. So I think referral from all clinical specialties are actually coming in. And in our institute in Medical College Thiruvananthapuram, we have started our operations probably about a little over 2 years. And we are actually having a handful of workload. So I think in the coming years as well, that would not be a problem as far as referral is concerned.
Is there any complaint from the surgeons that we are encroaching on to their field?
Not actually. I think as far as I don't know about private sector, but probably in the government sector there is no issues because The number of patients who are actually needing care is, I think, a lot more than the resources that probably we or even the private has. So I don't believe that, personally for me, there has not been any issue, and I think within our institute there has been actually a good coordination between all departments. So
The
yeah, it's
topic is open
complementary.
for complementary.
Yeah, yeah.
The topic is open for discussion. So any questions?
Yeah, yeah. Yeah. Yeah, the primary option does not come to a prostate artery embolization or a uterine artery embolization per se. So basically patients who are not surgical candidates are the larger majority of patients who undergo these procedures. Patients who are actually fit for a surgical procedure will have much more benefit and immediate benefit post your surgical procedures, unlike your embolization procedures, especially with regard to prostate artery, because in prostate artery embolization, what you intend to do is actually size reduction in order to relieve the symptoms. Now, when you do a prostate artery embolization for size reduction, it takes at least about 3 to 6 months for that to actually translate to size reduction and thereby to symptom. But with regard to your uterine artery embolization, if you're doing it for PPH, then it is a viable option because immediate resolution of your bleeding manifestation and correction of the hemodynamic status of the patient is immediate. But then again, when you're doing it for a fibroid in the uterus, wherein your symptom is not bleeding, but primarily of compression symptoms because of the large size of the tumor, you want immediate relief of those symptoms, you would slightly prefer to do a myomectomy or a hysterectomy depending upon the patient's age and family. For uterine as well as prostate, you have to do bilaterally because there is a numerous anastomosis between sites. So doing only one side may not serve the purpose mostly.
Any other question?
Thank
If
you.
there are none, we'll
Yeah, thank you.
close this session. Thank you very much, Dr. Lex.